worked in the first grad school, had been a MASH surgeon.
Why am I not surprised?
He was one of several physicians that I've met, psychiatrists that I've met in the public mental health sector, who were psychiatrists because their malpractice premiums got too high and whatever else they were doing. Changed. A lot of people don't realize you don't have to be board certified or have specialty training in medicine to be any particular specialist. You can just decide that you're focusing on something. I mean, hospitals sometimes enforce the certification, but it depends on where you live in the country. So, a lot of the psychiatrists that I worked with in my public mental health days have been surgeons or anesthesiologists or OB-GYNs, and then just switched into psychiatry.
So there's no distinction, no extra training?
If you're going to intentionally specialize and sort of do it right,
yeah,
and go for boards, yeah, there's a whole sequence of specialty training, but you don't actually have to do that.
If you think small town, the GP, the physician, he does everything. He takes out the tonsils, he takes out the appendix, he does everything. He delivers a baby.
There's a guy I went to high school with who holds himself out as a cardiologist in my hometown, who's not in cardiology. He's an MD, but I mean, he just decided that sometimes he's going to specialize in cardiology. I don't think he does heart transplant.
It's an easy one.
Does like licensing.
Oh, okay.
This is very interesting.
A pig valve replacement every now and then.
And it is more of an issue in public sector services and in rural states and so forth. So a couple of things before we get into today's lecture, and in case anybody's wondering, I've rated somewhere in the high 20s, I guess. 30s. I've got about 18 more exams to go. So I've graded 30-some. And you will also get feedback on your level of participation. I was just doing some of these, so generally I'm using, some people are sort of on the borderline between these, but I'm using like low, okay, and good. So like some people are like low to okay, some people are like good to okay. A few people are like very good. So I'm not exactly sure at this moment whether you have to have good to not change your grade, or whether okay would not change your grade. Obviously, good, you're in really good shape. Okay, you could probably talk a little more. If it's low, then you're probably at some risk of grade reduction based on your written materials at the end of the semester. Which could be something that would half a grade to maybe a full letter grade, how well it is. So one of the things I've been doing since I saw you last was flying to Iowa and back from Sunday to Tuesday, which is actually how I got most of the grading done. Grade papers on planes and airports and stuff. And I was there for a national conference on aging and mental health that combined 3 different groups, actually, that were meeting. One was the National Association of State Directors of Mental Health Departments has a geriatric division. So all the geriatric coordinators, state-level geriatric coordinators, geriatric mental health coordinators from around the country were there. The coalitions of aging and mental health, state-level coalitions of aging and mental health were represented there. As is true of a lot of things in the aging and mental health area, California actually doesn't have a coalition of aging and mental health. The Midwest is cut over some other parts of the country, the East Coast. And then the people that the National Association of the people that handle the pre-admission screening stuff for nursing homes have an association. The Passauer professionals are called. And they were also present there. And it's kind of an interesting update on what's going on. There was a guy from CMS, the Center for Medicare and Medicaid, who does their kind of their overview of the whole PASS-R system. And he seemed really, really enthusiastic about trying to make PASS-R actually mean something for mental health care and nursing homes. He hangs on and keeps on working on this. They actually grow some teeth for the next 20 years. It's been around for 20 years so far, and not a whole lot has actually happened with it, aside from people starting to fill out all the paperwork and file it. And then there was a lot of discussion of some like model projects around the country. Probably the one that actually did strike me as being somewhat new is there's a lot more focus on co-location of mental health and medical primary care medicine services. Particularly in Iowa, they've got a project going where they're really trying to find ways of making some of the national level program models work in a way that would be continuously supported by finance. And there's some models that people have been excited about for the last several years around health services research like impact and PRISM-E and so forth that can combine primary medical care and treatment of depression in older adults. But most of them, like some of the model projects, sort of have that problem that they're much more richly staffed than anybody can do just on like Medicare and Medi-Cal funding. So when the grant runs out, the services stop. We're trying to find some ways of setting up the same treatment systems that would actually get paid for by Medicare, and so could actually be kept going on an ongoing basis. In terms of the content, the other thing that I felt kind of reassuring is that finally people at meetings like this are talking about more than just dementia and depression. There's actually some attention to anxiety. Actually, given that the NASPAD people, geriatric mental health coordinators, are not too unusual. There's some focus on older adults with schizophrenia and other psychotic disorders. But also a real growing attention to substance abuse disorders, including one presentation on coming problems with marijuana abuse in the boomer generation. Go back and check this out. This is the first time I've heard this. The guy that was doing the presentation actually was citing some evidence that extensive prolonged marijuana use is a risk for heart disease. Really? For myocardial infarctions and strokes, both, which I've not heard before.
Well, it's because usually you don't smoke it with some sort of a filter, and it actually has more tar than regular tobacco, and so it junks up your lungs even more.
Quite possible.
Could be the munchies, too.
From 20 years ago, that was what we came up with.
3 pizzas and a beer or soda.
Camels are fatty, too.
Actually, one of the things that Mitch said was that there's not, the controlled study suggests that there actually is no connection between THC or marinol, the presumed active ingredients, and the munchies. And he was suggesting that it's actually, if you're smoking, it's because your throat is raw. No, that's why people want to eat things like ice cream and things that are soothing to your throat. You know, my long ago memories, you know.
Cardiovascular risk come from just like the fact that it's smoke?
That's one of the things we discuss. I mean, one of the overall problems is that there's so little research on the impact of marijuana. It's very hard to get the permissions and to get and to actually get the drugs, whichever version you're using, to do the research that we don't have anything like the health research that we actually do. You were going to say something else?
Oh, no, just that, because smoke is cancerous. I mean, like any kind of smoke has properties, and I imagine
especially, I mean, unfiltered smoke and smoke that you hold in your lungs even longer. Most people don't cigarette smoke. Anyway, the other thing that was kind of fun for me about the meeting was there were 3 alumni of our program. They're at different levels. Brian Caskey is a former PhD student of mine in gerontology who is